Thank you very much indeed, and thank you very much indeed to the HRB and the NREC office for inviting me to talk. And I'm going to talk about the landscape of Irish research ethics, and again, it's going to be a bit of a history lesson. I'm a disclaimer, I'm not an ethicist, I'm a clinician. I'm also a researcher, and I've also been involved in research ethics. So I actually see a lot of this from two different lenses. Ideally, they should be the same lens. We're all looking at it in the same way, but in reality, a lot of researchers are often very keen to pursue the research, very motivated, and often see research ethics as an unnecessary burden and a bureaucratic hurdle over which one should get to achieve your ends. But I think it's important to remind such researchers of the kind of issues, even in Ireland, that have created concerns over governance in many ways. And I'm a child of the 60s, and in fact I was born in 1960, and a number of people who were born at the same time, their mothers were given this drug, thalidomide, in an effort to stop morning sickness in a fairly unregulated manner. And a large number of children ended up getting severe malformations, and they are describing themselves rightly as thalidomide survivors, which means that many of the people who were exposed to thalidomide, the babies that were exposed to thalidomide, did not survive because of the teratogenic effect of the drug they were given caused severe malformations from which they did not survive. And it's still something that's with us today. And I think many of you may have seen the Australian government have recently issued an apology to people from thalidomide. But there was a lot of lessons to be learned about regulation. It wasn't used in the US, particularly by one doctor in the FDA who felt that there was insufficient evidence to it. But there was probably about at least 10,000 people exposed and damaged by thalidomide. And that made people think about the use of drugs and the regulations. And that's a legacy that's still with us. In our own Irish context, there were major issues about how both mothers and babies were treated in institutions, in mothers and baby homes, children orphanages, and children and industrial schools. And over those many years, there was a commission put together now, actually 20 years ago, to inquire into child abuse. And during that time, it transpired that at least 300 children were involved as participants, willing or otherwise, in vaccine trials and formula testing in a number of these institutions. The Commission then planned to investigate a lot of that further, but actually was stopped because there was High Court actions taken by two of the doctors who were involved, including from my own institution, who successfully made their case about them stopping that. So the decision was made not to look into that further. But that's still a legacy in many ways that Ireland has to deal with, not just with the whole issue of mother and baby homes, but also the use, as you've heard from Deirdre, of people in vulnerable institution populations who may not have the ability to give informed consent for these kind of trials, again, potentially for the greater good. Even when there's regulation in clinical trials, there can be significant problems. One of the more well-known ones was actually now it's 30 years ago from a US NIH study on a drug that was meant to be used for hepatitis. And in phase 1 early trials, 15 healthy volunteers were given this drug. 7 of them went into acute liver failure. 2 managed to survive with transplanted, but 5 died. There hadn't been adequate the animal studies hadn't shown liver toxicity, but in fact it was probably due to a damage of the drug to mitochondria. And actually there was an institutional investigation done at that stage, and the trial was considered to be conducted correctly, and this is described as a rare occurrence. Not a similar trial, but a similar event happened in the UK in Norfolk Park in a clinical trials unit in London, where an antibody was given simultaneously to 6 participants altogether at the same time, which obviously is one of the big concerns. And they all came profoundly ill and had what is known as a cytokine storm and spent some of them several months in intensive care with multi-organ failure. And then there was subsequent 2 investigations from independent groups and found that there was an inadequate preclinical workup. In fact, the drug that was being used was meant to block this particular molecule, but in fact it triggered it. It was a superagonist rather than an antagonist. There hadn't been an adequate workup of that beforehand. Medical records were not sufficient. Physicians with inappropriate qualifications were involved, and there was issues about insurance and getting coverage. So there was a lot of lessons learned, even in a regulatory environment. And in Ireland, there was an institute involved in clinical trials, the Institute of Clinical Pharmacology, and there was certainly one participant who died in the 1980s from a phase 1 trial drug at that time in Ireland. So these can still happen even when regulation occurs, and there are important lessons to be learned from it. So how has research ethics developed in Ireland? What has been amazing, I think, is the fact that in the absence of organisation, in the absence of funding, in the absence of trying to manage this, there's a whole load of people in a whole load of institutions right across of Ireland have taken it upon themselves to try and help researchers to actually try and drive and support research ethics. And so many institutions will have volunteer memberships from people who already have full-time day jobs. There may be no convener, administrative person that goes with it. There's often very limited access to statistical or other specialist advice and very little in the way of formal training except what people can find. And yet those research ethics committees have been working hard in a completely altruistic way to try and help researchers do better research. And that's been enormously helpful, but it's in a very unstructured way, and there's a lot of variety in that. My colleagues in the University College Galway had actually did a survey looking at the number of research ethics committees in Ireland. That was back in 2005, and there was 78 for a population of what would be under 5 million. And many of those were in voluntary institutions. Obviously, there are also universities as well, which are more structured. There was legislation that came in, obviously, in relation to clinical trials, which laid out criteria for ethical approval of clinical trials, which are actually very similar and based upon Nuremberg codes. And following that, the Department of Health then actually looked at the element of clinical trials, although not other research. And there were 13 committees across the country were felt to be able to, registered with the Department of Health to be able to look at clinical trials, and they had to reach a certain number of standards to be able to take that on. And that was actually quite helpful. And then subsequently, there was a regulation on allowing multi-centre approval for a single REC, providing multi-centre approval for clinical trials in Ireland. But again, it was a fairly ad hoc exercise and built on a huge amount of goodwill from many people. Again, I'll put my hand up for this one because I was involved in this, and there's a number of other people around here who I know are also involved in the Irish Council of Bioethics. This was an independent body. Interestingly, it was set up not by health, but by trade and industry, to try and provide a better venue for attracting investment to Ireland to look at bioethics. And it was hosted by the Royal Irish Academy, which was extremely generous and very supportive of the Academy, to look at bioethical issues in science and medicine. And actually one of the first documents that was produced was a document for Irish research ethics committees about operational procedures, which was of enormous help to people. There were other reports on things like research integrity, advanced directives, GMOs, and use of biological materials. Interestingly, one of the topics that I remember maybe somebody suggested we consider was looking at the ethical issues on pandemics, and everybody turned around and said, no, it'll never happen. We're not going to look at that. How wrong we were. And then as a result of the crash of 2008, when the IMF came in, the McCarthy report, it's not McCarthy, it's McCarthy report, looked at a whole lot of organisations, and then as a result of those cutbacks on board, SNP decided that there was no more of the Irish Council of Bioethics, so it was closed. And Ireland is still one of the few European countries that does not have an independent bioethical advice for their government, which is very regrettable, even in the days of plenty. And actually, this is something that was actually looked at again through the Royal Irish Academy at a meeting 2 years ago, again back to the point of rebuilding trust and discourse in the whole area. And that was an extremely helpful meeting. But again, it needs further action, not necessarily by the Academy, to see how far we can go with that. The other issue that's come, and we discussed a lot in the Council of Bioethics, is the issue of research integrity. Even if the Research Ethics Committee approves a particular project, you're very reliant on the researcher to do what they say they are going to do. And it's very difficult that some people have the assumption the Research Ethics Committee has a role as a policeman to make sure that those people do what they do. And that's something that I don't think any Research Ethics Committee actually able to do. So the area of research integrity is something that's normally out with what a Research Ethics Committee can do. But there are many concerning studies. The one that actually, maybe perhaps for my interest, is very concerning. There was a study put out in the mid-90s from a South African project where women with breast cancer were given extremely high-dose chemotherapy. And before they were given that, they had a large amount of their bone marrow removed. And then once they had the chemotherapy was actually then re-injected into them to try and help them recover. And this was a study from South Africa that showed that this was a significant benefit. It was then taken on and used for many people afterwards in trials and also actually in clinical service, but it couldn't show any benefit And then subsequently, when it was investigated, it was found that the author of that particular paper, they couldn't find the patients, they couldn't find the data, and it was factitious, the whole exercise, which means that large numbers of women with breast cancer were put through a very unnecessary, severe treatment by what is essentially the research fraud that was involved. In my own area, David Baltimore, who's a Nobel Prize winner and was president of the Massachusetts Institute of Technology, ended up having to resign over a paper that was submitted by one of his research staff with his name on it, where there was a suggestion there was fabricated data. And after a long exercise and a lot of legal cases, it transpired it was a matter of error rather than actual intent. So again, one shouldn't assume that all of these things that are wrongs are necessarily intentional, but they certainly create difficulties. And this is something that the Irish universities have taken on board. The Irish Universities Association got together about 12 years ago to produce useful guidance and discussion about research integrity. One can't assume that we're better than anybody else, that research issues can happen in any country, and they can. And more recently, and I would give tribute to Maura Heine, I'm not sure if she's here, but for the European Code of 2017, there's a whole European group looking at a code of conduct for research integrity, which was recently updated. And that's been rolled into a lot of universities who've been able to have processes and procedures for research integrity, particular identified staff to be able to deal with that. It's not something that every research institute, every research group, particularly in the healthcare setting, necessarily has, but it certainly needs to be put into place. And the other area that's made a huge difference, again, about autonomy, about involvement and sharing, is the whole area of patient and public involvement. And I know we're going to hear about it later. This is a government-funded, I suppose, group partnership on recruiting people for excellence inspiring, which is the PPI Ignite network, and that's been really helpful in putting people together. This is the Health Research Charities of Ireland, and I'm glad to see Avril is here today, who's the CEO of that group, which is a group of health charities who come together to put their views on how research should be done and their involvement in research. And also IPOSI, and Derek Mitchell has been involved in that for quite some time. Again, getting patients involved. And that does not mean just being a patient being involved as a member of a research ethics committee. It's much more important than that. It's actually patients being asked by the doctors who are carrying them, what are the issues that they would like to study? How would they like to help develop the strategy? How would they like to be able to work with the project design? Reviewing the information and the leaflets that their patients are going to be given before it ever goes near a research ethics committee. And then promoting that research and educating people about it afterwards. So it's very much a collaborative exercise, and I'm very lucky that for many of the conditions I deal with, there are very active and good and supportive organisations to help with that. It's really important. What's also happened to the Irish area is obviously GDPR, and I'm not going to mention too much about that today, but the health research regulations were developed in 2018 around the same time as GDPR driven that, and that led to the establishment of the Health Research Consent Declaration Committee, which is essentially an organisation under the auspices of the HRB, which is great, which looks at situations where the waiver of consent may be considered a possibility in relation to research for lots of different reasons. And that was fine. The second bit, where there was a bunch of research regulations that were, I'm afraid, not the Departments of Health's finest hour. They produced a version that actually was very difficult to deal with, and the quotes from, not from me, but I would agree with them, they're from other researchers, saying that it lacked consultation, it created confusion, it had an impact on trial participation and on training. And there was a lot of things about whether or not individuals who might want to do a study were actually allowed to look at the medical records of patients who might be into that study, or should you get a different person to be employed to do what you could do. Thankfully, but it did take 3 years, that there were amendments that actually made those regulations workable. For those 3 years, it was quite difficult. One of the few things, the very few things that came out of COVID that was a benefit was actually something that I was involved with. I know a number of my colleagues were also here, was a National Research Ethics Committee for COVID. And that came together virtually during COVID to approve large numbers of studies. We had 93, and actually most of them were approved right across the country in many different areas. And it showed that having a National Research Ethics Committee, and it was almost like a pilot, an accidental pilot for the NREC, which is obviously now I'm part of. And again, you have the National Office for Research Ethics Committees, which has been a huge help, but it's again for clinical trials. I also want to pay tribute to Anna Terrace in the HSE because she's done a huge amount of work in giving much more guidance on through the HSE on research ethics, which was something that would be seriously lacking before, giving guidance for researchers and for research ethics committees about how to pursue this, and how to do research and how to do it in an ethical way, and very sensible and practical guidelines. And that's been really, really helpful for many researchers and also for research ethics committees. And following on from that, and some of you may have seen the roadmap that was handed around, this is a suggestion now, a proposal of how to reform research ethics committees, with essentially having 6 regional research ethics committees with the remit within the HSE at least, not every other area, in terms of healthcare, to be able to approve research. And I think that's been a big development, and I'm looking forward to the way that happens. So if you look at any landscape, you'll often see a few blots. There are still things that I think need to be developed further. One of my big concerns, and I'm sure I'm not the only one, is, and in a way Deirdre may have mentioned to it as well, is the over-legalisation of patient information leaflets. For legal reasons, for GDPR reasons, that you can have I think the record is 75 pages of a patient information leaflet for a patient, somebody who might be participating in a research study. If you're somebody who's actually sick, you don't have the time or the mental headspace to be able to get into any of that. Much of the language is dense. It hasn't been tested on anybody who's actually in the situation. It's written without their own review. And I think that's something that's really difficult. If we want to be serious about getting informed consent, it has to be improved. And that's not exclusively for clinical trials. It can also be for other projects as well. There are big issues still about recruitment or retention of research ethics members. They need to be provided and able to, and most of them are very keen to pursue education. But more importantly, that their time that they give should be recognised, not necessarily for lots of anything else, but their institution should realise that they're carrying a vital part of what's done and have recognition, so they have time to do that. There are still issues for the people who are doing clinical studies that are not trials in multiple centres. They still have to apply to large numbers of research ethics committees and getting different opinions and different timescales and rewriting different information leaflets all the time. Extremely frustrating for researchers, I can tell you. And I've already mentioned greater patient and public involvement. I'm not sure all of you have read this, but last year the government introduced, Rialtas na hÉireann produced the Ireland Research and Innovation Strategy 2030, aimed at what we're going to look like in 2030. That's our minister holding the tag with lots of the leading lights in academia, who are glad to have them involved. And that research strategy has a whole load of elements into it, including what they want to achieve in terms of new research, excellence, looking at creating new talent, and then integrating with EU and global research. If you actually look through the document, you won't find ethics. So I would suggest to the Government of Ireland that actually there should be an additional goal to all those, which that if they're going to have a serious strategy, that the research strategy should be carried out to the highest ethical standards. It sounds banal, but it's important to say. And the Research Ethics Committee should be fully resourced to actually help those researchers and work with them, not against them. We're not on different sides, to achieve the standards of much better research. Thank you very much.